Hello everyone, this is Dr. Sandeep Madaan, your anatomy faculty at DAMS. So today I'm going to discuss the solution for this anatomy quiz which was conducted on my Telegram group. This is the link to the Telegram group. If you want, you can just go there and check the questions, or else just follow me with the solutions. So here, this was the question where the 50-year-old man comes to you with the complaints of dry eye. For proper evaluation, Schirmer's test is performed. Anatomically, this test evaluates the function of each of the following marked muscle. So basically, we know the Schirmer's test is for the lacrimation, and for the nerve for the lacrimation should be greater petrosal nerve, which carries the preganglionic parasympathetic fibers, right? So among these given option, we have been given this image A, B, C, D. Let us identify these nerves over here, right? So here, this is the facial nerve. We all know the facial nerve. In this posterior segment, it will be giving one branch over here, that is nerve to stapedius muscle, but here this is giving this branch which is chorda tympani. So A is the chorda tympani nerve, right? And here you can say this is the middle ear part over here, you can see, and then we can also see the inner aspect of the internal ear, right? So here this nerve is entering along the floor of the middle ear, and it should be the Jacobson's nerve, the ninth nerve branch, which will make the tympanic plexus in this promontory area. So this will be the Jacobson's branch. But we can see these two nerves, C and D, which are present, we can say, which are present in the on the petrous part of temporal bone, right? Petrous part, above the petrous part of temporal bone. If they are above the petrous part of temporal bone, means we can say these are superficial petrosal nerve. So we have two superficial petrosal nerve, greater superficial petrosal and the lesser superficial petrosal. So we can say that, like, normally we call them as like greater petrosal and the lesser petrosal, but their true name is greater superficial petrosal, lesser superficial petrosal. So C and D both are the superficial petrosal, but C is the greater petrosal nerve, and D is the lesser petrosal nerve. Okay, B is the Jacobson's branch or the tympanic branch. Okay, and A is the chorda tympani, which is a branch of the facial nerve. This one is the facial nerve over here. So that is why answer to this question will be C, right? That is the greater petrosal nerve. Can you see? This is the seventh nerve, chorda tympani branch, the ninth nerve, which is giving the tympanic branch over here. We have the greater petrosal nerve and we have the lesser petrosal nerve over here, right? Now moving on to the next question, which of the following clinical finding is not seen in the lesions of structure following the passing through the jugular foramen? Now, who passes through the jugular foramen? We all know that is ninth nerve, 10th nerve and 11th nerve. So we have to see these A, B, C, D, they will be because of 9th nerve, 10th nerve or 11th nerve or not. So palatal palsy, palate is supplied by, the muscles of the palate are supplied by VAC, that is vago accessory nerve, vago accessory complex, where the 10th nerve is involved along with the cranial root of 11th nerve is involved. Definitely this will be seen. Difficulty in shrugging. Now this is called as shrugging, right? It is done by the trapezius muscle, and the trapezius is supplied by the spinal accessory nerve. So that is why that will be also seen. And the posterior 1/3 of the tongue is carried by ninth nerve. So answer will be C, which is actually under mandibular nerve. So that will be the answer over here, right? So answer is C. Next question, one of the following opens in the middle meatus of the nose. What you have marked, dear friends, here, right? Answer will be maxillary air sinus, right? That is present in the middle meatus. Nasolacrimal duct, where it opens in the inferior meatus. It opens in the inferior meatus. And the Eustachian tube opens, it is like present behind the inferior concha. Behind the inferior concha. Sphenoidal air sinus will be opening in the spheno-ethmoid recess. I'll show you all this, okay, with the help of the diagram. Spheno-ethmoid recess, that you're going to see this sphenoidal air sinus. Let us see this part. So we have the three concha, which are the projections, right? Between the concha we have the meatus. So this is the inferior meatus, where you will see this nasolacrimal duct is present. It is opening, okay? And whenever you see the sagittal section, always observe behind the inferior concha, you will see the opening of the eustachian tube. Okay, the nasopharyngeal opening of this eustachian tube will be present over here. But in the middle meatus, what you observe that there is something which is called as bulla ethmoidalis. What is bulla? It is a projection in the ethmoidal bone. That is why called as bulla. But below the bulla, you have one hiatus semilunaris. It is a gap hiatus, semilunar shape hiatus. Okay, so who will be opening in the hiatus? That will be fam. That will be fam. Like what is fam? Fam is the mnemonic. F for frontal, A for anterior ethmoidal, and M for maxillary sinus. But who will be present on the bulla? That will be middle ethmoidal. Who will be present in the superior meatus? That will be posterior ethmoidal. Because ethmoidal we have a group of sinus, so you can see anterior, middle and posterior, they all are present in line. Do you understand this? So now who opens in the middle meatus? We will include both the structures opening on the bulla as well as the hiatus part. And in the hiatus we have fam, on the bulla we have middle group of ethmoidal sinus, right? Now regarding the sphenoidal sinus, that is opening in the sphenoethmoidal recess over here. That is why that will be considered in the sphenoethmoidal recess, and answer to this question will be middle meatus. Now where is the opening of the nasolacrimal duct? Is it the inferior meatus? This question has been asked number of times previously. That is the natural opening, right? But when you do the dacrocystic rhinostomy, that time you create the artificial opening. It is a created opening just because if the duct is kind of blocked. Okay, that is the clinical anatomy. Also, what we can learn over here, that we have a common plate. Understand this part. We have a common plate which is hiatus, and on the hiatus on one side the frontal sinus is draining into it. This is the frontal sinus, and from here maxillary sinus also draining into it. So if suppose some patient is having the frontal sinusitis, the collection of the frontal sinus will drain here into the hiatus, and from the hiatus it can reach the maxillary sinus secondarily. So you can say maxillary sinus is kind of a reservoir for the frontal sinus. Do you appreciate this? Now moving on to the next question. A 52-year-old man complains of the dryness of the mouth. An examination, he lacks the salivary secretion from the submandibular gland. This indicates the lesion of which of the following nervous structure? So here answer will be B, coda tympani. Why? Let me explain with the help of this diagram. Now here we can say this is the tongue, right? What you can see over here is the tongue, and the nerve approaching the tongue, this will be lingual nerve. This will be lingual nerve. And if this is tongue and we can see one gland below the tongue, can I call this gland as sublingual gland? And this gland here will be submandibular gland. But what will be this structure? This structure is submandibular ganglion. This will be submandibular ganglion. Now if you pay attention, both the gland as well as ganglion, they have the name submandibular because of their position. But one is the salivary gland, the other one is the ganglion. So what will really happen? This nerve over here you can see is the coda tympani. This coda tympani nerve will be approaching over here, and it will merge with the lingual nerve. It will relay in this part over here, that is in the submandibular ganglion. It will relay. After relay, what will happen? Few fibers will simply go over here. Few fibers will simply travel and they will reach this gland, and few fibers will go with this nerve and will reach the sublingual gland like this. Do you understand? So this is the pathway for this submandibular and the sublingual gland. And the ganglion involved here is the submandibular ganglion. The nerves are who is holding the ganglion is the lingual nerve, but who is bringing the preganglionic fiber is the coda tympani nerve. I hope that makes sense. But apart from that, we can identify other structures also here, right? What else we can see here? We can see this is the auriculotemporal nerve. Auriculotemporal nerve, because we can see this nerve is having the two roots. Between the two roots we have one artery. Can you identify this artery between the two roots of auriculotemporal? This is the middle meningeal artery. Very, very important artery, right? So that is the relevant information from this question, right? And so answer to this question is coda tympani. We have learned coda tympani has got two roles. One we have just now discussed, that is it will deliver the salivary fibers to the submandibular ganglion, and from there eventually the fibers will reach the submandibular gland and sublingual gland. So one role is to deliver the salivary fiber, and the second role is to carry the taste from anterior two-thirds of tongue, right? So coda tympani has got these two roles. Next question, a patient complains of loss of sensation from the tip of nose branch of which nerve will supply the tip of nose? And here answer will be anterior ethmoidal nerve. Why? Because here we can see the three divisions of the ophthalmic nerve. We have, this is a V1 fibers. This is the lacrimal branch, so it is going to the lacrimal gland. This will be the frontal branch, which is further dividing into supraorbital and supratrochlear. But this nerve is the nasociliary, which will give these two branches over here, that is anterior ethmoidal and posterior ethmoidal. Now if you closely observe this picture, where these ethmoidal nerves are going, they are going from the orbit, they are going above. Now to see their course, what we can do, we can dissect this part. If you dissect and clear the region, you will get this picture. Now you can see this is the anterior ethmoidal and this is the posterior ethmoidal nerve. And here we can say the anterior ethmoidal nerve, from the orbit it has reached the anterior cranial fossa. From the anterior cranial fossa, it will enter into the nose like this. From the anterior cranial fossa, it will enter into the nose like this. In the nose, it will divide into two branches, medial and lateral. The one which is on the lateral will come on the surface as external nasal branch, right? So that is how you can say this will be supplying the tip of the nose. Now something which is very important for us to understand, that normally we understand that we have like this is the part for the maxillary nerve, above we have the ophthalmic, below we have the mandibular nerve, correct? So even though this is a territory for the maxillary nerve, but anterior ethmoidal nerve or the branch of ophthalmic nerve has traveled from inside. It does not have any outer course like that, right? So I hope you understood this, and now we'll be proceeding to the next question, right? Next question is, a drummer presents with the hearing loss, and on examination what is observed, that there is loss of contraction in the tensor tympani and the stapedius muscle, right? And eventually the question is, which nerve will be controlling these muscles? So tensor tympani is supplied by which nerve? We know it is supplied by nerve to medial pterygoid, which is a branch of trigeminal, specifically it is a branch of mandibular nerve, right? And the stapedius, we have the nerve to stapedius, which is a branch of facial nerve. So mandibular and facial nerve are the specific answer, but among the given option we can mark B choice. Now this image is given, lesion of what will lead to paradoxical respiration. Now first thing, what is paradoxical respiration, how it takes place? Understand this part carefully. We have the two domes of the diaphragm which are supplied by the phrenic nerve. Now just imagine one of the phrenic nerve is gone. This particular part will become flabby. It is no longer a muscular contraction, it won't follow. But this is normal. During the inspiration, this dome will go downward. But this flabby membrane, this flabby part will not even maintain the position. Why? Because during the inspiration, there is a negative pressure in the intrathoracic region. That negative intrathoracic pressure will suck this part above. So the normal dome is going downward, the flabby part is going upward. It is the paradoxical movement. And why it happened? Because of the involvement of the phrenic nerve. Now this image has been given to us, where we have to identify which one is the phrenic nerve over here. So we can say this is the subclavian artery, which is getting divided into three parts by this muscle. So this muscle should be scalenus anterior, okay? And here we have this subclavian artery branch, which is called as thyrocervical trunk. The thyrocervical trunk is giving this branch inferior thyroid, transverse cervical, and the suprascapular. It is also giving one branch downward. This should be internal thoracic. It is cut here, but it is internal thoracic artery. But now the question is, what is A? A is a nerve which is just anterior to the scalenus anterior muscle, and that is the identification criteria for the phrenic nerve. So that will be the answer. A is the phrenic nerve. That will be the answer, because we know that A is just anterior to the scalenus anterior. Then what is B? B is also anterior. It's a nerve which is anterior to the scalenus anterior. So both phrenic and vagus are anterior to the scalenus anterior. But how we will identify? We will identify by the fact that phrenic will be just anterior, vagus will be further anterior. So what is A is the phrenic nerve, what is B is the vagus nerve, and what is C is the artery, that is subclavian artery. But what is D? See, whenever you get these type of images in the exam, you will immediately, when you look at the image, you will be able to come to know about certain points, certain things that you will identify just by looking at it. But some of the structure you have to trace. For example, here we can see this is the deltoid muscle, right? And here we can see the bony attachment of the deltoid. So we know that bony attachment of the deltoid on the other side, the same bony attachment will give attachment for the trapezius. So this is the deltoid, this should be trapezius. Now we are looking at a nerve which is running down the posterior triangle and going to supply the trapezius muscle. What it should be? It is spinal accessory nerve. So answer to this question will be A, phrenic nerve. A is the phrenic nerve. What is B is the vagus nerve. What is C is the subclavian artery. And what is D is the spinal accessory nerve. Next, this is pretty easy question. The question, like, patient has come to us and you ask him to look to the left side, you ask him to look to the right side, but on the right side he cannot see with this eye. That means this rectus is not working. Which rectus? As a clinician, you must inculcate this habit of making a proper diagnosis, a complete diagnosis. So here, instead of saying lateral rectus is not working, you should say right lateral rectus is not working. So which nerve is gone? Instead of saying abducent, you should say right abducent. Even though in the question or in the option right left has not been given, that's okay. But we must learn proper way, right? So it is the right lateral rectus and the right abducent nerve which is gone. But yes, from the option point of view, we will mark A as the answer. Now this question, the patient has come with the lack of tears. Which of the following nerve may be damaged, right? So here we have the lacrimal nerve, we have the zygomatic branch of the facial nerve, lesser petrosal, greater petrosal. So let me first describe this, right? Let me first describe this part, how this lacrimation will take place, and then I'll show the same in the image. Okay, so basically what happens that we have the greater petrosal nerve. Greater petrosal nerve will come in this ganglion, which is called as pterygopalatine ganglion, where the relay will take place, and after relay these fibers will be carried by the zygomatic branch. The zygomatic branch will be actually dividing into two branches. It will be dividing into zygomatico-temporal branch and zygomatico-facial branch. But zygomatico-temporal branch will be giving one further branch to the lacrimal nerve, and lacrimal nerve will be supplying the gland, that is lacrimal gland. So zygomatico-temporal nerve will be going here and it will be joining here. Now see this part in this image. Can you see the pterygoid plate over here? Can you see the palate over here? Pterygoid plate on one side, palate on one side. This is the pterygopalatine fossa. And in between we have the pterygopalatine ganglion. This is pterygopalatine ganglion. Now here the relay will take place. After the relay, this is the zygomatic branch. This is the zygomatic branch of maxillary, not the zygomatic branch of facial. Zygomatic will divide into zygomatico-temporal and the zygomatico-facial, and the zygomatico-temporal will give one communicating branch to the lacrimal nerve. This nerve is the lacrimal nerve. Now these fibers will go and supply the lacrimal gland. Now please pay attention. Even though the lacrimal nerve is supplying the lacrimal gland, that's okay. But the proximal part of the lacrimal nerve, if you cut the nerve here, but the distal part is intact. Proximal part of the lacrimal nerve, if it is cut, it won't lead to the loss of lacrimation. That's why among this given option, we can mark only greater petrosal nerve that will be responsible for the lacrimation. Proximal part of the lacrimal nerve cannot lead to it. It can be distal part. Then there will be loss of lacrimation. Regarding the zygomatic branch of the facial, no, that will be motor branch which supplies the muscles on the face. But zygomatic branch of maxillary, yes, if you cut that nerve, then the pathway will be affected. So that's why D is the answer here. Now this particular case, can you tell me the name of the syndrome over here? What happened here? So here answer will be critical stenosis in the first part of the subclavian artery A. Why? Because if you see, this is the arch of aorta, from where you can say the left subclavian, you can see the left common carotid, this is brachiocephalic trunk, right common carotid, and the right subclavian artery. This will be right vertebral, this will be left vertebral, and this will be the basilar artery. So basically, if you look at the flow of the blood will be going above. Flow of the blood should go above, and it should go above in the basilar artery. And from the basilar artery, the blood should go to the cerebral circulation part, which is the circle of Willis. But what happens, sometimes there is obstruction over here. If the obstruction is here in the proximal part, the blood which was supposed to come here, it cannot come. If the blood can't come from this side, the blood will keep on going from here. Some blood will keep on going just like previous, but some blood will start coming in this direction, and then it will fill the subclavian artery. That means now, instead of directly getting the blood from the arch of aorta, it will be getting from the opposite side of vertebral artery. So obviously pressure will be less and pulse will be weak. And if you see, look at this way, this subclavian is getting the blood which was meant for the cerebrum. So it is as if the subclavian is stealing the blood, as if the subclavian is stealing the blood. So we can say it is subclavian steal syndrome. It is called as subclavian steal syndrome. And if you ask this patient to go for Doppler ultrasound, okay, in the Doppler ultrasound we can see the blood flow. In the Doppler ultrasound you can see the blood flow. Blood normally should flow in this direction towards the basilar side, but in this patient the blood is flowing in this direction, just opposite direction. So that is one of the, you can say, characteristic feature, that reversal of flow of blood, that will be signifying this. And this is only possible when there is a proximal obstruction. So I hope that makes sense. And here you can see the pulse was weak and the BP is less, around 30 mm of HBP is less, okay, and the Doppler showing the reversal of flow. So we are definitely sure. And these features were exaggerated or initiated by using the arm. Why? Because now the arm is getting the blood which is kind of somehow managed from the circulation. But if this patient uses the arm, then the demand will be more. And to compensate for more demand, more blood will be cut off from the cerebral circulation. And that's why the features will aggravate, right? Now this question is pretty easy. The patient going for thyroidectomy, okay, and you are looking at a structure which is accompanying the thyroid, inferior thyroid artery. Please remember this mnemonic RISE. So RISE means we have recurrent laryngeal nerve which accompanies inferior thyroid artery, and external laryngeal nerve which accompanies superior thyroid artery. So the question is, inferior thyroid artery, you are going to ligate and you are searching for a nerve. It should be recurrent laryngeal nerve. Now this is a favorite area of the examiner's, pterion. Read everything about the pterion. It's very, very important. Now in this particular question, who lies deep to the pterion is the anterior division of the middle meningeal artery. Anterior division of the middle meningeal artery. Anterior division of middle meningeal artery. This anterior division of middle meningeal artery is actually most common cause of extradural hemorrhage, and this is a branch of the first part of maxillary artery. Okay, so B will be the answer over here. Now this particular question, which of the following is the function of the mark muscle? Now let me explain this way. This picture is given. This will be the ramus, outer muscle will be the masseter, this small muscle will be the temporalis. Can you see this bony plate? That is the pterygoid plate. Just lateral to this pterygoid plate we have the lateral pterygoid, and medial to the pterygoid plate we have the medial pterygoid muscle. So same pterygoid plate, lateral and medial, we have different muscles, right? So here we can say we have, like, if we do the labeling, we can say this one will be the masseter muscle, This one will be the temporalis muscle. Okay, this marked muscle is lateral pterygoid, and medial, this part will be the medial pterygoid muscle. You appreciate? This particular muscle will be medial pterygoid. Now, having understood that lateral pterygoid has been marked, we can say what this muscle, like the question is what is the function. So it can do the protraction, because protraction is done by both pterygoids, but it can't do the retraction. As again, it can do the depression but can't do the elevation. So A and C both are true, but you have to choose one. We will mark C, because depression is done by only muscle of mastication, that is lateral pterygoid. Otherwise you can say protection will be kind of shared muscle. And what is given in the Gray's anatomy, that the component of the protraction is actually required for the depression only. Okay, so again we'll mark answer is C only. Now this particular question, we have to look at the structure which will pass through the both superior orbital fissure as well as common tendinous ring. Why so? Because we know there are certain structure who will pass from the superior orbital fissure. Who will pass? See, if some wire is passed from the superior orbital fissure, it will be reaching the orbit where the eyeball is there. With the eyeball, we have the extraocular muscles. So we can say those structures should pass from the fissure who has something to do with the eyeball movement. That means it's motor nerve supply. What is the motor nerve supply for the extraocular? That is, all are supplied by 3, LR6, SO4, correct? So 3, 4 and 6 nerve will definitely pass from this particular fissure. But the point is, it is not that only motor component has to pass. We have to bring in the sensation also. Who will bring in the sensation? That is the first division of the trigeminal, that is ophthalmic nerve. Okay, so ophthalmic nerve will divide into 3 divisions. So we have now got third, fourth and the sixth nerve, third, fourth and sixth nerve, and 3 division from the V1 fibers, which will further divide into L, F and N, lacrimal, frontal, nasociliary. Okay, but these will pass from the superior orbital fissure, but everything will not pass from the common tendinous ring. Let me show you the diagram. Here we can see the common tendinous ring, but this is the fissure. This particular part is superior lateral part of the fissure, and this is also fissure but through the tendinous ring, and this is the inferomedial part of this fissure, right? Like that. Making sense? Now, how will we remember? We will remember LFT. LFT is left outside the ring. Outside the ring means through the superior lateral aspect. Who is LFT? Lacrimal, frontal, trochlear. And who will pass through the ring? The remaining nerves. Who is remaining? Third nerve is remaining. Fourth nerve has already passed, so it will be not counted. Sixth nerve is remaining. Okay, so you can say the oculomotor nerve and the abducent nerve and the nasociliary nerve, right? These will be passing through the tendinous ring. So here LFT will pass through the fissure but outside the ring. Now only one structure which is passing through the ring, that will be abducens nerve. That's why D is the answer. So thank you so much everyone. I hope you like this video. Okay, and if you have liked this video, please you hit the like button, and you can comment your feedback, and please subscribe and share the video. Thank you so much. All the very best.